everyone. Hope you are doing great. Thank you for attending the 10th part of HU LATAM webinar series. In these sessions, we're going to talk about introducing the Harrisburg University, the researches that are going on, and also different programs that we are offering at Harrisburg University. My name is Rozbe Sedigian, and I have the honor to be the host of this series. Harrisburg University is a private STEM-focused university in Harrisburg University, Pennsylvania, with an additional location in Philadelphia. HU has more than 30 programs in undergrad, grad, and PhD level that are representing 6,000 students from 110 countries. HU LATAM will offer a Master of Science in Data Analytics, Project Management, and Cybersecurity, which will be delivered in a hybrid format, which means it's going to be online and on-campus classes right in Panama right now and later on in other locations. The faculties will be coming from United States, from Pennsylvania. For the hybrid sessions and also for online sessions, they're going to be the same faculties. We are going to have scholarship for the first few cohorts too. So without any further talk, let's start with our first speaker, which is Michael Sievers. He is the Healthcare Informatics Program Lead. Dr. Michael Sievers is an assistant professor of healthcare informatics at Harrisburg University. Dr. Sievers has a varied background in IT, business, healthcare, spanning many decades. Dr. Sievers began as a programmer analyst at Shared Medical System and later at General Electric in their aerospace division. Dr. Sievers then began working at Book of the Month Club, where he managed an application department focused on order processing and pick, pack, and ship algorithms. Later, as a senior project manager, Dr. Sievers worked for Hanover Direct during the dot-com initial years, working with major corporate clients like Sony. As the dot-com industry went bust, Dr. Sievers moved to the healthcare industry. Dr. Sievers worked at Capital Blue Cross for nearly 2 decades. The first decade was as a senior manager in the IT department, and the second decade as the senior director of claims and later the senior director of enrollment and billing. Dr. Sievers' focus was automation of labor, for instance, in the way of robotics for healthcare. After a varied career background and various formal degree, Dr. Sievers is very pleased to be teaching at Harrisburg University of Science and Technology. Dr. Sievers, the floor is yours.
Okay, thanks for having me. Let me share my screen. Give me a second here. Hopefully you'll be able to see that very quickly. And I will bring it up to full presentation mode. Hopefully you can see that. And I am actually going to bring up a pen just for my benefit. And one of the major things that we talk about at Harrisburg University, especially with the current situation that's going on, is COVID. And I just wanted to go over some things that what has COVID done from a perspective of healthcare with data collection, vaccine passports, and finally telemedicine. Those are the focus items of today's thing that I'm going to present. I don't know if you know it or not, but from data collection, we've seen major issues with standards in collecting of the data. Myself, I'm on a couple committees with the state of Pennsylvania, and we've collected COVID data over time. And the one thing that we found was we were missing a lot of social determinants of health data that had to do with gender, race, sexual preference, and those type of things. The hospitals weren't collecting it, and they definitely weren't providing it at all. And some of the other issues that we just are starting to see is with these at-home tests, they're supposed to provide the information back to the family doctor, but we're getting less and less of the information being provided because of these this information. The other thing that we're having a challenge with, and this is across the world, is what fully vaccinated really means. I was just talking to the Pennsylvania Physicians General just today, and fully vaccinated doesn't mean to have the booster shot, not yet. And across the world, it's not yet as well. So definitions of not fully vaccinated sometimes means just one particular shot and not another. So the standards are really a question mark when it comes to COVID, and that's one thing that we're definitely struggling with. The other thing that COVID has brought on is vaccine passports. There are names of different things along the line, but most people call vaccine passports. Some people call them health passes. And the first fundamental question of these things that we discuss at Harrisburg University is, what is the purpose of these vaccine passports? Originally, it was for travel. Especially international travel. But now it's gone well beyond that. It's to get into a concert, a restaurant, anything like that. And what data are we really looking at? The United States has taken a different approach than what the European Union has. The United States is really just looking to see if the person is vaccinated. That's basically the definition of a vaccine passport. The EU has expanded upon that of not only having that particular definition, but if you had COVID and when. That is another way you might be able to get into a restaurant. Another one is a negative COVID test within the last 2 weeks is another opportunity. So the EU has made a standard. They've put a software platform in place, and these are the three components that they have agreed on, but not all countries have agreed on that. Some logistical issues that have come up with these particular vaccine passports that we talk about at Harrisburg University is not all vaccines are certified in all countries. In the United States, for instance, Sputnik and China's vaccine are not certified in the United States. So what really is a vaccine passport? And then the World Health Organization really has some issues with how some countries are doing boosters, and even a couple different boosters whenever other countries need the vaccines and need to distribute the vaccines. So that's a logistical issue. The ethical issues actually has to do with, especially at the beginning, the Northern Hemisphere countries were getting a lot more vaccinations or vaccines than the Southern Hemisphere countries, and a burden on the low and the middle income countries as well, trying to get these vaccines. And the final thing that we'll talk about a little bit later is the digital divide that has really been emphasized with COVID that we talk about at Harrisburg University. With vaccine passports, it's paper versus electronic, and US and the EU are much different. The EU has a much better standards when it comes to smartphones than we do here in the United States. We're basically paper, but some people do have some of those electronic options. The other thing is, in the US, there isn't a standard from a software app perspective. There's different ones. I've gone to a conference and it had one. I went to a restaurant. It had you needed to use another one. My mother is in an assisted living spot, and I have to use a different one for that. There's no standard. And here in the United States, we have some challenges between the states themselves. New York and Hawaii, there are states that require like a vaccine passport, whereas some states have actually banned them. Indiana and Arkansas are examples of where they've been banned. So we have a challenge here in the United States, to say the least. And fraud, how to detect it and to see if it's fake or not. New York Senate passed a bill that made it a crime to do a fraudulent form. Here in the United States, this is what we have. We basically have a paper form that has been created by the CDC, and there's data that's put on it. Now, granted, this is high in a fraud situation, and in November of 2021, the Society for Human Resource Management came out to say to employers, how do you detect a fraudulent paper, one of these type forms? And this is what they came up with. And as you can see, that's not really a major situation where you're saying, was it cut by scissors? Was it inconsistent or misspellings? If you're doing it from a fraudulent perspective, you probably already know not to do it this way. Now, with EU and some of the software companies here in the United States, this is what a vaccine passport is on your phone. And most of the time, the standard has been green. When I visit my mother in assisted living, it is a green item that comes up, and there's a 3D barcode that also comes up. And it's amazing. They never scan the barcode for me when I go in. They just need the green, and they wave me in. But if you've ever seen the health passport, they've gone a different direction. They've actually made it red. So these are some of the discussions that we have in Harrisburg University of, okay, should it be a green standard, which normally across the world, green means go and good, versus a red standard, but this red standard means everything's okay. So here's a quote from the World Health Organization's Senior Regional Advisor for International Health Regulations. When talking about vaccine passports, there is a huge hope to get out of this pandemic, and anything that sounds like a silver bullet is sort of embraced. Unfortunately, we see more and more that there's no silver bullet, especially when it comes to vaccine passports. The final thing that I want to go over with you tonight, what's coming out of COVID is a much bigger focus on telemedicine that we've never had before. That's good, bad, and different. I just need to go over just the definition of telemedicine, especially here in the United States. There's different categories of telemedicine. One is live video, just like we're doing here tonight. However, you can do it just strictly by phone, just by voice and audio. There's remote patient monitoring. I'll get to that in a second. And a thing called store and forward with images, x-rays, consults, things like that. With dermatology, telemedicine has definitely been on the front runner, that and behavioral health as well from a telemedicine perspective. Now, remote patient monitoring, there are different devices that you can have in your home that can be real time. The good old Internet of Things can push this data over to your own doctor. And yes, it's blood pressure, glucose monitoring, pulse, thermometer, scale, wearable devices, the Fitbits and things like that. Can be hooked up and sent over to your provider. So we at Harrisburg University, we talk about these things. We discuss the new remote patient monitoring and those type things that are actually on the market. So with COVID and telemedicine, what are some of the different aspects? Here in the United States, and this is coming from the American Medical Association, good or bad, COVID has been a catalyst for telemedicine here in the United States. With video telemedicine, this is from the American Medical Association of September of 2021, looking at data of 2018 to 2020. Now, remember, 2020, we were in the throes of COVID. So we went from video telemedicine from 14.3%, essentially prior to COVID, to 70.3%. So suddenly the patients had to know how to deal with telemedicine, and more importantly, the providers and the hospitals had to be set up for that as well. Remote monitoring went from 10.1% to 20%, so it doubled unto itself. Provider to provider consults went from 11.6% to 26.2%. So huge changes with those, but the store and forward, believe it or not, there was not any changes there. So huge increase, but what we've seen from the Health and Human Services here, the federal government. This just came out February 1st, 2022. They released these particular statistics on in 2021 what was happening with telemedicine here in the United States. In April, for all adults, that was anybody 18 or older, 26% was still using telemedicine. By October, it's down to 20%, but that's still higher than the 10% that was prior to COVID. From a race perspective, believe it or not, our African American population is using it more than the white population, but it was between the April and October of last year. These are some discussions that we have at Harrisburg University on, okay, why the discrepancy that's happening, to research a little bit more directly. And what was happening is from a white perspective, people were going to the doctor, obviously more from a travel. Education, this was an interesting one. All across the board, all educations, they were the same, 20 to 24%. There wasn't any difference in higher ed versus no high school education. That was one of the amazing things I thought that was just released. Household income, believe it or not, the lowest income ranges here in the United States is actually still using the most from a telemedicine perspective versus the highest. And from an age perspective then too, anybody that was older than 24 years of age, it was basically the same across the board, much like education, 20 to 24%. So some telemedicine issues that have popped up. I'm not sure about where you live, but here in the United States, these are some of the things that really popped up. Who pays for it? Because there are two arguments with payment of telemedicine visits. The health insurance companies here in the United States, their argument is simply that, hey, look, you don't have an office, you don't have the equipment, you don't have to pay for the electricity, etc. It should be less. Telemedicine visit should be less. Providers and hospitals are saying, you know what, you're right, but now we need the IT infrastructure. We needed to increase the baud rates that were coming into our systems so that we can share X-rays and or other images. We need the video that's up. So the IT costs for an office went down. The general cost for an office went down, but the IT costs went up. So we have things called parity laws here in the states in the United States. And what that simply means is a telemedicine visit is equal to and should be paid the same rates as a hospital or a regular on-ground visit. The other issue that we have here in the United States is nurses and doctors are essentially licensed at the state level, but with telemedicine, you can easily go overstate. It's more of interstate commerce than it is inner of the state commerce. So telemedicine needs to be larger boundaries, and we've faced that along the way. Here in Pennsylvania, the governor and the legislature allowed doctors that are in neighboring states all the way around us to also be able to practice medicine here, telemedicine here in Pennsylvania. Finally, we need to talk about that digital divide. And people have divided the digital divide, sorry for the pun there, into two categories. One has to do with the internet connection, and the other has to do with the equipment connection. And until about 5 or so years ago, those were definitely two issues. But what we've found, and this is Pew Research February 8th of 2021, so it's a year old, but 97% of the US population actually owns a cell phone and 85% utilize a smartphone. In 2011, only 35% of the US population has had a smartphone. And of the 85%, there's even more of a percent that actually has a laptop or a PC. So our equipment issue on the digital divide is somewhat being solved. But the internet issue is still an issue here in the United States. 6% of the US population, per the FCC, the latest report, still doesn't have internet connection. That's 19 million people. that potentially need it. And of the 19 million, 14 million live in rural populations. So the digital divide is still an issue, especially when it comes to internet connections. So here at Harrisburg University, these are some things that we talk about, especially because there are current issues. COVID has caused these particular things to be highlighted. Data standards are issues. Telemedicine has cropped up, and these vaccine passports are just a question mark across the world. So you're probably wondering, what is healthcare informatics? And this is the definition from a large organization called the Healthcare Information and Management Systems Society. It has over 100,000 members internationally, and this is the definition of healthcare informatics. Promotes and understanding, integration, and application of information technology in healthcare settings. And a lot of times it has some analytics lens to it as well. So with our master's in healthcare informatics here at Harrisburg University, I'm going to focus on year one. Dr. Mitchell will talk about some things with 699 or 695 and 699, those particular projects. But our core courses at Harrisburg University have to do with healthcare systems. It's not just the healthcare system in the United States, but we look at healthcare systems throughout the world. An basic intro to healthcare informatics, and a specific course on healthcare data that we cover data governance in healthcare organizations. We talk about data dashboards, which COVID has really proliferated as well. And we get into a lot of the standards, HL7, FHIR, and some of the CPT, ICD-10 codes and things like that. And then Intro to Analytics is going over many different models that you need in healthcare, from regression to linear programming to simulations, forecasting methodologies, and even queuing systems. And then finally, the Essentials and Skills 1 and 2 is really an entire course, but over 2 semesters. And this gives you all the skills that are necessary for a healthcare informaticist here in 2022. For instance, cybersecurity to project management to agile to lean to visualization. Many different aspects on dealing with difficult people, teamwork, and we really concentrate on presentations because we truly believe that it's not just analytics, but how you present that data as well. So quick summary, COVID has changed a lot for us. That's a lot of things. This is one thing that we talk about at Harrisburg University. Magnified the data issues, vaccine passports, not sure where it's going, and increased telemedicine. So that was my presentation. Hopefully you got some things out of it, but at the same time, we welcome you to have any questions on the Masters of Healthcare Informatics as well. Thank you.
Thank you. That was a great presentation. If you have any questions, feel free to type in chat and I will share it with Michael. I don't see any questions coming. We just had one question about if this presentation is going to be shared. Yes, all the presentations in these info sessions is recorded and will be shared on Harrisburg University YouTube channel. I put the address in the chat box so you can refer to it if it is needed. So thank you. Oh, I had a quick question, Dr. Sievers. I've heard that, I heard it a lot, as you mentioned, too, that this is going to, telemedicine is going to be the future of healthcare. But some also believe that it happened just because of the COVID, that most of the people are going to that. Do you think it's just a peak, that's something that happens once and it's going to fade away eventually, or you think it's going to be stay like that?
Well, as the numbers are really showing, first of all, telemedicine has been around, okay, before COVID. The catalyst is COVID, and a lot more people were utilizing it. Obviously, in 2020, huge spike. But yeah, we have gone down, but it's still looking like about 20 to 25% of the population is utilizing telemedicine. I know that my wife uses it and is very comfortable with it. It had to do with it getting comfortable utilizing it, but will it be 70% like it was in 2020? Probably not. And then there are certain things you just still need touch in doing some things with health. But at the same time, COVID has increased it, and it's going to stay that way for a long period of time. And the future generations, they're getting familiar with it. If we have more and more wearable devices that can monitor different things, telemedicine will be here to stay.
Great.
Thanks.
Thank you. Yeah.
Thanks for the question. I'm going to stop sharing now.
Okay, so let's move to our second presenter, Dr. Glenn Mitchell. Dr. Mitchell is professor of healthcare informatics at Harrisburg University of Science and Technology. He is also vice provost of institutional effectiveness and program lead of ISM doctorate. He was previously a senior consultant at Numeroff and Associate Inc. in St. Louis, MO. During 2007 to 2012, he was chief medical officer for the Sisters of Mercy Health System, responsible for establishing the Center for Medical Informatics and the Center for Quality and Safety, as well as leading the full spectrum of successful physician-related programs such as EHR implementation, ICD-10 conversion, evidence-based medicine use, physician leader development, and system-wide strategic planning for all clinical service lines. For 30 years, he has been involved locally and nationally in the development of provider and staff education and leadership development. During his career, he has been full-time faculty at Brown University, also his alma mater, and adjunct faculty at several institutions, including St. Louis University, University of Texas Medical Branch, and Uniformed Services University of the Health Sciences. Dr. Mitchell is a retired Army colonel, past president of the Aerospace Medical Association, former vice chair of the American Board of Preventive Medicine, and fellow of the American College of Emergency Physicians. He has authored over 40 publications and has received numerous military and civilian awards, including the Defense Superior Service Medal, 3 awards of the Legion of Merit, and the Secretary of the Army's R&D Achievement Award. Dr. Mitchell, please.
Thank you, Rosba. I appreciate the introduction. I wish my mother was alive to hear that. You did very well. Thank you. Tonight, I want to talk about what's happening today in healthcare technology, and we'll overlap a lot with informatics, as you heard from Dr. Sievers. I'm going to show some slides along with my talk that are a little different. They're graphic, so you don't have to watch me, but it's really meant to sort of go along with the stories that I am going to tell. I'll show these slides for about 15 to 20 minutes of talk, and hopefully you will have some questions at the end. So I want to mention some significant trends in healthcare technology today. And the first is really that we are using the electronic medical record data more and more to improve patient care for both individuals and population groups. One of the things that happens in medical informatics is that we talk a lot about dashboards where data is presented in visual form. And they look sometimes like the one in the upper left of the graphic. And they're trying to convey to you information on either your patient and helpfully trying to be helpful about your diagnosis and your assessment of the seriousness of their problems. And also there are screens which summarize how your patients as a group are doing for specific problems. It may be blood sugar control for your diabetics and all. And there are references on dashboards to help you assess how well you're doing as a physician or as another healthcare provider by comparing them to national norms. Are you better or worse than the average medical practice in the country? And it's very helpful. And one of the things we've found, however, is that dashboards, which used to be built into electronic medical records, are really very personal. And that individuals see things differently. Some people like to see graphs. Some people like to see numbers. Some people see colors differently. Almost 10% of the world's population is colorblind in some way. So they might not be able to understand what the dashboard is trying to do if the colors are chosen badly. So there's a lot of time being spent on developing dashboards to get this data that we're all entering into computer systems now, to try to get this data in front of providers so that they can give better care to individuals and better care to all the patients they have in their panel. So that's a big deal, and we spend a lot of time at it in informatics. But as Dr. Sievers mentioned very briefly, there's also this incredible use of Internet of Things devices today. And they're used to extend fairly sophisticated care and monitoring to both the home environment and to chronic care facilities that just aren't connected to a hospital and have limited resources. A lot of these are really very interesting. Of course, we all know Fitbits and other electronic watches that we can use to monitor our sleep, monitor our heart rate. A lot of people are terribly into fitness, and I worry about taking 10,000 steps a day. But these are really very popular across the whole population, especially here in the United States. But we have lots of things that are available. We have our Alzheimer patients at home or in a care facility that wear devices that alarm when the wearer leaves a defined area. That the device uses GPS to know when the person wearing it has wandered off the grounds and maybe in danger of being lost or being hurt. So those are very useful for the increasing number of patients we see today who have Alzheimer's disease or other dementias. There are necklaces, of course, that sense falls and can call emergency care by themselves. Our insulin pumps now measure your blood glucose and regulate your blood sugar by changing your insulin levels and all by themselves. And they also can call to your care team, your doctor and nurses, that report low blood sugars or high blood sugars. That's pretty good. But there are other things that are creeping in now as Internet of Things devices that put more and more data in the hands of individuals as well. I have a Sleep Number bed, which is a bed that actually gives you in the morning a rating on how good your sleep was. It measures whether you were restless or whether you slept soundly, whether you got up during the night, what your heart rate was, what your heart rate variability was, and it gives you a whole picture of how well you've been sleeping and advice on what to do to improve your sleep, which seems to be connected to some improvements in your health. People love these. I'm also incredibly disappointed when it gives me a poor score when I've slept overnight. That's probably because I'm a doctor and I've been used to competing for grades all my life. I hate getting a bad grade. There's now a thing called from LG. It's a refrigerator that can scan the codes on your food. And it identifies foods by those codes. And it's capable of understanding that you've bought foods that you are not supposed to have and can call your doctor and let your doctor know that you have foods that are interfering with your treatment plan. One of the common examples is that if it senses that there is grapefruit juice in your refrigerator and you are taking medicines to lower your cholesterol, many of those medications are inactivated by grape juice. grapefruit juice. And it'll call your doctor and say, there's grapefruit juice in the refrigerator. Talk to your patient about this because it's going to interfere. And of course, one of the things you saw on Dr. Seaver's list is one of my favorites, and those are the scales that can not just report your weight every day to your medical office. Most of those are due to people who have congestive heart failure and are worried about retaining fluid and gaining weight rapidly. But they can also just plain track your weight. And what I don't like is that they will tell you in a computer voice in the morning if you've been gaining weight recently. And that always happens to me during holiday seasons. And I don't like my scale telling me that I'm gaining weight. So other things that are going on, there's some incredible efforts out there right now to try to help providers so that they don't have to concentrate on computer data entry during a patient visit. This is a big problem right now with patients in this country, with their dissatisfaction with their doctors. It definitely is interfering when your doctor is staring at the computer screen, looking at paper when you're on the exam bed behind the doctor. The picture in the lower left here is precisely what most people see today in this country, which is the doctor on the computer, and you're sitting there on the exam table. And the doctor is not looking at you. The doctor is typing things into the computer. This is a problem. And what we all want is what's on the right. We want the doctor to be looking at us. We want the doctor to be interacting with us and talking and establishing a relationship and building a trust. And it's become much more difficult today. So people have been working on it. And recently, perhaps over the last 2 years, a company called Nuance has developed a system that listens like Alexa and all those computer assistants that listens to the doctor and the patient in the exam room and can actually type out the medical note for the electronic medical record. And the one they have projects the note on the wall behind the patient so the doctor can see it. And it translates normal conversation into a medical note with using medical terms, which is quite great. And it takes that note when you're finished with the exam and you've agreed on what the patient needs and you've talked about an antibiotic, and it gives you the prescription and it says, do you want to send it to the patient's pharmacy? You verify that with the patient, talking to them, and tell them, it'll tell you so you can tell them at what time the prescription will be ready at their local drugstore. This is going to be an amazing improvement over that staring at the computer screen. This is all happening in the next few years. And then there's a second step to that hasn't been done yet, that is a challenge today. And I think this is a very exciting one. And that is, we're improving the assistance with patient management through artificial intelligence and natural language processing, by searching the literature and by looking at the patient's record information, and trying to help the doctor manage the patient. Originally, about 5 or 6 years ago, it was a project that IBM undertook with its Watson computer, which has tremendous speed and can execute deep learning algorithms very quickly. But they've lately given it up, and they're actually selling it off. So I'm hoping that other groups pick up on this project because it will be a huge advance. The computer can actually scan the medical literature in real time and also review the patient's record in the computer system you have, and ask you as a provider if you have considered a particular diagnosis because it isn't noted in the chart or you haven't talked about it today. And it can offer improved treatment plans or new treatment plans that are out there in the literature for you to consider. So it doesn't take away your autonomy and your authority as the provider, but it helps you to make sure that you're trying to keep up with a medical literature that is impossible to keep up with by yourself. I remember there's a medical paper published every 30 seconds, 24 hours a day, 7 days a week in the United States alone. The computer could even point out where there are clinical trials for unusual or serious diseases. So this project really needs to be pursued much more seriously and soon. And it's one of the things that I tend to talk about at national meetings, trying to get people to make sure we are not forgetting this. If you're interested in this particular aspect of medical care and improving patient contact, you can always watch an 18-minute presentation on this. If you Google TED, T-E-D, Harrisburg, and Mitchell, that you can listen to my TED Talk that's there on YouTube. Well, that'll pop right up as Google's #1. So it's a good thing to have if you can't sleep. You can watch my talk for 18 minutes. So there's always there is a problem with what's going on today too that needs to be addressed immediately, and that's burnout of healthcare providers. The COVID has created an incredibly stressful environment. As you remember, the world wasn't prepared for this in terms of personal protective equipment, in terms of staffing, in terms of number of ventilators. This has been an incredibly emotionally draining experience, especially for the healthcare providers that are faced with this for shift after shift after shift. What I saw this past week was that almost 500,000 persons in healthcare jobs across just the United States have quit during this past year. This is going to require both new personnel management approaches and improved psychological tools to support providers, as well as a larger educational pipeline for new workers to replace those who are retiring, both on-time retirements from the baby boom, people in my generation, and those that chose to retire early because they were completely exhausted by the COVID pandemic. We're just beginning to consider all the solutions to this huge problem, and that really will take some time. I suppose any group discussing technology and medicine should include a few words about robots and surgery. The Da Vinci robots have been around for a lot of years now, and robots were often discussed as taking over all of medicine and being able to do virtually anything. And they do offer a number of obvious advantages in the short term. There's reduced post-surgery pain, there's less blood loss usually, but as far smaller scars, there's real precision in what is removed or for joint replacements. Usually patients recover faster, there's a shorter hospital stay, and there's usually less risk of infection. This is done in an extraordinarily sterile environment. So ordinarily, I'd be praising the great results from robotic surgery and probably trying to sell you one if this talk was happening 10 years ago. However, in this last few years, several evidence-based studies of long-term outcomes have shown little difference between older techniques, open surgery and laparoscopic surgery, and robotics procedures in terms of the outcomes of the patients. Surgery for cancer hasn't resulted in vastly improved lifetimes. The surgeries done for other reasons have also finally had some major problems with if there is an inadvertent cut of an artery, there can be major blood loss before people intervene. And at that, the fantasy of telesurgery with a doctor sitting in one city and you being operated on in another city by a robot and the doctor controlling the robot really hasn't worked out terribly well because of connectivity problems in the infrastructures of all of our countries. So actual long-term results are not that different from robots and not robots. And there's now some serious discussion starting about the real benefit versus the incredible cost of robotic surgery. And especially when Alzheimer's outbreak has really sensitized us to brain problems, and the long anesthesia times for robotic surgery, almost twice as long as open surgery, are causing post-anesthesia syndrome with its interference with some brain function to be really reconsidered. So I'm not quite as thrilled with robotic surgery as I was 10 years ago. So I want to talk to you for a few minutes about what's going on at HU. And the HU research is really an area that is very near and dear to me. Part of my job as the vice provost is to increase the amount of research grants and research participation that we do at Harrisburg. So I will talk about a few of them. We have several programs on the graduate level that focus on research and can involve healthcare-related projects. But all of our programs are built so that collaboration between programs is really part of the system. Students can take electives in the other programs of the university for whatever their interests really are. And many work on joint projects across disciplines as they work on the capstone experience, those 695, 699 that Dr. Sievers talked about, the research experience that is part of their degree program. Of course, at the master's degree level, we have an excellent healthcare informatics program, as you just heard from Dr. Sievers. I say that with a smile because I founded that program originally and turned it over to Dr. Sievers a few years ago when I became the vice provost. Informatics has had many graduates who have produced influential studies and published their theses. That's pretty important. Two students worked together to perform a groundbreaking survey of physicians about their acceptance of telehealth, especially that was done during the early part of the pandemic. We connected them to the chief medical information officer at a large hospital across the street from our main campus, and they published their work in a major medical journal. Another student assessed acceptance by providers and patients and their families of medical robots used in telehealth applications, such as in assisting with stroke diagnoses in rural hospitals. Another student built a prescriptive mathematical model just using Excel for nurse scheduling in the emergency department, and that reduced nurse staffing hours in one hospital by 15%, just by abandoning the standard shift start time model that we've been using for so many years, at least in this country. So by changing shift start times, major nursing hours were saved. And when nursing personnel are in a shortage, as they are now, especially with people quitting, this is a very important tool. And this will become extremely important for our hospitals and their staffing. Two other students, I've looked at different aspects of implementation of high-tech dentistry tools and the techniques used in general dentist's office across the country. And their work in terms of how the acceptance is going, what the positive and negative factors were in telehealth, and some cost-benefit analysis. Their work was adopted by several dental professional organizations for their use in provider education programs, in trying to get older dentists in practice to buy and adopt the latest technology. And that's certainly been a major positive development in dentistry. I know not very many of us like going to the dentist, but when the dentist can actually take pictures of the inside of your mouth and have a crown for your tooth manufactured in his office while you're sitting in the chair, is certainly different from the old days of having to send out impressions and get things made and keep coming back to the office to have it fit, etc. This has really freed up a lot of our time, as well as being so much more accurate than the impressions that used to be taken. So that was those were really very interesting, but there are other master's degree programs at HU that can easily involve research into healthcare topics. In analytics especially, this program has a concentration area in healthcare data analytics. the future of useful dashboards and using the available data for individual patient management and for population healthcare management are located in this program. In fact, the program is tightly connected to the informatics program and shares many courses between them. Our master's degree in information systems engineering and management has areas of artificial intelligence, natural language processing, image recognition, and complex data mining that are all important to the ability of the electronic medical record system and its major data repository to be more useful. Our human-centered design master's has students working on dashboard displays that really minimize the number of clicks you have to perform to get important information about the patient who's sitting in front of you, and it summarizes for you the outcomes of that patient and the panels of patients compared to your benchmarks while the patient's in the office in a way that you can understand most quickly and most clearly. That's a fantastic development. Our project management folks have students in a multidisciplinary effort to construct complex healthcare project designs, such as detailed plans for implementing new electronic medical record systems in healthcare facilities with the least cost and the least aggravation of the staff while all this change is going on. Now, we also have an esports program, and competitive computer gaming is incredibly popular across universities across the United States, and Harrisburg University happens to be a national champion, so we're very proud of this. But recently, we've begun using personal monitoring devices, daily diaries of eating, sleeping, and exercise, and sophisticated eye movement tracking devices to begin to define what makes a champion computer gamer. And of course, we'll also be finding answers to whether or not you should keep trying to stop your children from sitting with their computer screens and smartphones all the time. What is their harm? We will be following their academic success as well as their gaming and comparing them to students who just game part-time or students who don't game at all. And we expect to learn a lot that will help families figure out how much they really need to restrict their children from their gaming behavior. We're really pretty proud of that. That looks like fun. I should also mention that Harrisburg University has 2 PhD programs that offer research opportunities in healthcare. A recent data sciences PhD graduate student published improved real-time algorithms for identification of priority potential adverse drug reactions by using deep learning and artificial intelligence. And this is a major advance for instead of just a dictionary lookup of what's published, it really goes through literature and goes through a lot of source material very quickly and is doing much better at not giving silly drug warnings like don't take Tylenol and ibuprofen together, which is just not true. And the programs that have been out there in the built-in computer systems really haven't been very sophisticated. One current information systems engineering and management PhD candidate is designing a cost-effective extension of broadband connectivity in order to spread telehealth delivery to rural areas that don't have access locally to healthcare facilities. And another candidate is developing diagnostic algorithms that assist with better sensitivity and reliability of diagnosis of cranial MRI scans for Alzheimer's disease. So this is an exciting time to be in healthcare technology. Muchísimas gracias por su atención. Preguntas.
Thank you, Dr. Mitchell. That was a great presentation. I don't see any questions coming. We had a question, but I asked for clarification, but didn't hear back. And the question, my guess is that the question was if we are offering any sort of certificate of healthcare informatics, not a complete degree. Do we have such a thing?
Yes, we do. We designed in the core curriculum of the informatics program can be done in 1 year as a certificate in healthcare informatics. And contacting Dr. Sievers, he'd be happy to facilitate anybody who is interested in a certificate program.
Thank you. That was very helpful. Do you want to add anything, Dr. Sievers?
Actually, as Dr. Mitchell stated, it's the 6 core courses, and that's actually what I went over in that one slide. Those are the 6 core courses in the certificate program.
Yep.
So thank you.
Thank you. Thank you. So that's it. I need to thank all the audience for being with us tonight, and then thank Dr. Glenn Mitchell, Dr. Michael Sievers for that great presentations. We really enjoyed it. Also, I need to thank Dr. Kevin Huggins. He is Director of HU LATAM. Thank you for being here. And if you enjoyed this talk, don't forget that next month we're going to be here again. Next month talk is about gaming and how gaming can help with education. Thank you everyone again, and have a great night.
Gracias a todos.